Okay, it's 7 o'clock. Good evening, everyone. Let's start. So, welcome to the 16th edition of the master classes, which are conducted by the Jaipur Surgical Tutorial. The theme today and tomorrow is carcinoma of the stomach. For those of you who are joining the master class for the first time, just a brief introduction about Jaipur Surgical Tutorial. This is a free, no registration fee. Uh, Online education portal for surgical students, mainly MCH students in GI and HPV surgery. But I see that a lot of general surgery students have also joined us, which we have been running for last more than 3 years. This is being uh, this is being moderated and controlled the activities by my colleague, Dr. Anand Nagar, who is a professor of HPV surgery and liver transplant with me at the Mahatma Gandhi Medical College and Hospital in Jaipur. In the Jaipur surgical tutorial, every Saturday morning, 9 to 10 India time, we conduct an online session where students by rotation, they present cases or operative procedures which are discussed by the faculty. And all these classes are recorded by a team from Dr. Avinash Tak, who's my former fellow from SGPGI and now a consultant GI surgeon at Dwarika Hospital in Ahmedabad. About 1 year ago, we started these master classes, which are done on the last Wednesday and Thursday of the month, 7 to 9 p.m. India time, where we select a theme and we have two sessions of 2 hours each. In each session, we have one or two moderators and three or four panelists to discuss aspects related to the theme, and then there is an open house session. Also, under the auspices of my current institution, the Mahatma Gandhi University of Medical Sciences and Technology, we have been conducting an annual continuing medical education activity called Jaipur Surgical Festival. We've already done 3 festivals in last 3 years, and the fourth festival this year is 6 to 8 December. The theme is complications in surgery. So all those who are interested to attend in person can visit the website. If you put Jaipur Surgical Festival in the search, it will take you to the website. And in any case, we will be also streaming the entire proceedings live on various platforms with the help of the team from Dwarika Clinic. So all the students are welcome to attend live. And all these activities of Jaipur Surgical Tutorial, the master classes, and the previous 3 Jaipur Surgical Festival, all the videos have been uploaded on the YouTube channel of Gastro University, which are free for students to watch. So with that brief introduction of the JST, JSF, and master classes, I come to today's first part of the 16th master class of Jaipur Surgical Tutorial. And today, I have specifically requested my former colleague from SGPGI and currently a professor of surgical gastroenterology and liver transplant at the prestigious All India Institute of Medical Sciences in New Delhi to moderate this session. Dr. Das has had, like me, the fortune to work with one of the leading esophageal surgeons of the country, Dr. T.K. Chattopadhyay, and I think a large number of those of us who do esophageal surgery have learned the tips and tricks from him and are trying to take it further. So with that background, I would hand over the session to Dr. Das to moderate. Also joined is my colleague from radiotherapy, Dr. Anushri Loyal. She will be participating actively tomorrow, where she would be giving us a brief overview of the role of radiotherapy in the control of bleeding and especially unresectable carcinoma of the stomach. Thus, I may log in, log out in between for some personal reasons. So please continue to moderate, and wherever required, I will chip in. In between the sessions, for the sake of students who are joining for the first time, I will project information about as to how you can join various activities of Jaipur Surgical Tutorial by contacting my colleague, Dr. Anand Nagar. So with that, over to you. And I also specially welcome Dr. AIIMS, who is a a very senior surgeon from the neighboring country of Myanmar. We have never met, but we have been corresponding on email and WhatsApp for a long time. And I hope that we will see Dr. Aimon in India sometime. And I am hope that I will be able to carry a group of Indian faculty to Myanmar to conduct a CME program in your country. So welcome, Dr. Aimon, to the.
Thank you very much. Yeah.
Das, please carry on.
Thank you, sir. Thank you very much. With your due permission, I want to correct a little bit. I was never your colleague in SCPJ. I was your student. Now I have become a colleague in the Gastro University, of which you are the vice chancellor.
No, all of you are my very eminent, very prominent colleagues. I'm very happy that all of you have done so well that you can take over all these activities from me gradually. Please,
Yes,
please.
sir. Yeah, you are absolutely correct in saying that I have learned a lot of this gastric. I was into this gastroesophageal surgery because of the influence of Professor T.K. Chatterjee in AIIMS. And I am into active research in gastric cancer since 2007. So we have been conducting surveys in North India and all those areas where it is very, very rampant, you can say. Now, this cancer itself has been a headache to the human being since long time. Now, as we are sitting here, about I can see 10 people. One of us is likely to develop cancer in a lifetime. 10 out of 1 out of 10 in India. That's the Indian statistics. That's what the ICMR 22 study says. And there are about 100 per 1 lakh population cancer suffering from new cases of cancer. Stomach cancer, once when we were studying, it was called the cancer of death, the captain of death. But I think due to the rapid development in early diagnosis, particularly the molecular ones, the immunology part of it, the early diagnosis, early treatment, it is possibly no more occupying that dangerous position which it was having, and we are now being able to satisfactorily treat and get a acceptable longevity of survival, complication-free survival, recurrence-free survival, according to the standard of malignancy that is prevailing all over the world. The two important parameters that determine the survival or recurrence rate for most of the type of cancer, particularly the GI cancers, one is the margin, one is the lymph nodal status. So there is no question about these two. Others may vary. The margin part is a debate, and I think we will discuss this one in the next session tomorrow when we discuss about the surgery. And the lymph nodal status is very important for gastric cancer management. And though we have a difference of opinion in the Western versus the Asian data or Asian practice, I have seen some of my teachers or seniors practicing according to their own, you can say, guideline. Their guideline is to follow whichever guideline comes in their way. In the sense, if they like this particular surgery to be done, or this particular method to be adopted for management of the gastric cancer, they will apply the particular guideline which is suitable to them. So thereby I mean that still the guidelines varies. Still the Japanese people are conducting trials to establish what is there in the European literature before actually accepting them. So to know the management of the cancer, successful management of the gastric cancer, we need to know the incidences, the etiology, the molecular biology, the genetics, early diagnosis, management, recent developments in the investigation aspects, particularly the imaging, the PET scans, the endoscopies. There are lots of development in that. So to know the management, we need to know what is the etiology, and to know the etiology, what we need to know what is the surgical anatomy of the stomach here. The more or less, there is no confusion regarding the vascular supply of the stomach, the layers of the stomach, the parts of the stomach. All these are more or less standardized, not much of a variation. Where there is actually the variation and things are changing with time, and the differences between Asian and European communities and other areas also. So that is the lymph nodal anatomy of the stomach and lymph nodal retrieval, the status, the importance of lymph nodal dissections. So to know this, let's start with the discussion of the lymph nodal anatomy of the stomach. And for that, I will be, with the permission of Professor Kapoor, invite again Dr. Aimon from Myanmar to give his talk on this particular topic, which is important for us, and I think it's a very important for students' point of view.
Good. Thank you.
Dr. Aimon, please.
Yeah, okay. So good evening, everyone. This is my very first talk to the GST masterclass. Really thanks to Mr. Professor Vicky Kapoor inviting me to such a very honorable class. So today my topic is lymphadenectomy of the stomach, especially in relation to the gastric cancer. This is the basis anatomy topic. As Dr. Dash talked previously, it's very important to know these lymph node anatomy for the diagnosis and later surgery. So, carcinoma is one of the very common cancer worldwide. The lymph node spread is a very most common mode of spread. So, lymphadenectomy is essential for the acute staging and R0 resection. The stomach has a very rich network of the lymphatic drainage in the submucosal layer and very dense lymphatic network in the bidirectional omentum and mesentery. So in the textbook, they describe the stomach has the largest number of regional lymph nodes of any organ in the body, largest number of the lymph node in the stomach. And the lymph nodes are designated to the organ, the attach, or by the renal artery. It follow. For example, here this is a cardia stomach. We got here lymph nodes, the right paracardia, left paracardia. In the pylorus, suprapyloric lymph nodes, infrapyloric lymph nodes, and spleen-hylar lymph nodes. And then sometimes they tell according to the artery, leg gastric lymph nodes, ciliary lymph nodes, etc. So basically we all know in stomach, here's the lesser curvature, greater curvature, and the cardia here is a pyloric entrance and pyloric canal, and anterior and posterior surface. So the importance of the lymph node spread, first we must know detail about the arterial supply, as Dr. Dash described previously. And the stomach mainly supplied by we all know this is the ciliary tract. That's from ciliary tract, this is the leg gastric, which mainly supplying the cardia and the upper part of the lesser curvature. And then spleen artery, which go behind the stomach into the spleen, and that spleen artery give the multiple short gastric artery to the greater curvature and leg gastroepiploic artery. And then another artery is a right gastric artery, which come up from the common hepatic, which is one of the main branch of the ciliary tract. Right gastric artery is supplying the lower part of the lesser curvature region, and the another artery is a right gastroepiploid, which come out from the gastrointestinal artery. These arteries supplying also very important to study the lymph node groups. But in general, we have the stomach lymphatic drainage in 4 zones described in the undergraduate students. And then arbitrarily, we divide stomach the right half and the left half. The upper tooth of the right half, mainly the Lasaka region, including the cardia, they usually go to the superior gastric groups or lymph nodes. Basically, then lower third of the right half go to the suprapyloric group of lymph nodes. And another half, near the along the greater curvature, above that go to the pancreatico-splenic lymph nodes. And the distal tooth of this left side mainly go to the inferior gastric subpyloric group. These all lymph nodes finally go to the along with the vessel, they reach to the celiac group, then to the para-aortic and systemic. So here the full lymphatic channels are zone 1, 2, 3, and 4. Previous I mentioned, finally they go to the gastric, splenic, and hepatic and celiac lymph nodes, then to the para-aortic and systemic spreads. Then again, we can describe the lymph anatomy or the stomach at a three group. Here, the right paracardia, left paracardia, and the lesser curvature lymph node, greater curvature, suprapyloric, infrapyloric. These 6 groups are known as the perigastric group. In other words, they call the tier 1 group, or there's a compartment 1 lymph nodes. Then here the 7, here is a leg gastric, 8 hepatic, and 9 celiac. The 10 splenic highland and 11 splenic artery, they are the second tier group. They are not extragastric, but very near extragastric group. From them, they reach to the hepatic highland 12 and 13, 14, up to 16. They are the far extragastric group. That means that we have the 3 division of the lymph node very basically. I will mention detail about the lymph node into the station. First, the perigastric lymph nodes, tier 1 lymph nodes include lymph node station 1 to 6. We also know at the compartment 1 in staging, there is the N1 lymph nodes. Station 1, previously known as the right paracardial lymph nodes, is along the, there is a ascending branch of the, first branch of the ascending limb of the left gastric artery. No? This is the station 1 of right paracardial lymph node. Station 2 is known as the left paracardial lymph nodes. It related to the exubicocardial branch of the left saprophrenic artery. This is station 2. Station 3 denotes along the lesser curvature. Either here 3A and 3B. 3A is along the distal branches of the left gastric artery, 3A. And the 3B is the distal branch along the distal branches of the right gastric artery. So in the lesser curve, there are 3A and B. And the greater curvature, they are the station 4, 4SA, at above the greater curvature along the short gastric artery. Then 4SB along the left gastroepiploral artery. But the 4D and the distal portion of the greater curvature, this is branches of the distal part of the right gastroepiploral artery. So generally, the station 4s are along the greater curvature. Station 5, previously we know the suprapyloric group. This is the proximal part of the right gastric artery. This is the suprapyloric station 5. Then station 6 is the infrapyloric lymph nodes. This is usually we divide into detail 6A, I, and V. 6A related to the right gastroepiploral artery. 6I along the infrapyloric artery. 6V is the lymph nodes along the confluence of the right gastroepiploral vein. This is station 6, generally we know as the infrapyloric lymph nodes. So station 1 to 6, we got the tier 1 or compartment 1. This is the perigastric lymph nodes. Then the another stage 7 to 11 are known as the near extragastric lymph node or tier 2 lymph nodes, or complement to lymph node. These stage 7 is related to the left gastric artery at the main trunk of the left gastric artery, stage 7. Stage 8 is related to the common artery. 8A is anterior to the common artery. 8B is posterior to the common hepatic artery. Stage 9 is ciliate artery lymph nodes. So 7, 8, and 9 around the ciliate trunk. Here's the tier 2, main tier 2 group. Usually, most of the perigastric lymph node finally reach to that tier 2, 7, 8, and 9. And stage 10 is the splenic hyaline lymph nodes. It's got along the splenic artery, splenic hyaline, distal, quite close to the pancreatic duct. That's stage 10. Stage 11 is splenic artery lymph nodes. So along the splenic artery, they are the stage 11. And 11P is a proximal portion of the splenic artery. 11D is the distal portion of the splenic artery. The demarcation line is the posterior gastric artery. So with stage 7 to 11, we are known as the tier 2 or compartment 2. Then the very distant extragastric lymph nodes, tier 3 lymph nodes are station 12 to 16. Compartment 3, here the station 12 is generally known as the hepatic hilar, and near the hepatic hilar. Is the 12A is along the proper hepatic artery, 12B along the portal vein, and 12B along the common hepatic binders. Generally, these 12 lymph node station 12 are around the hepatic hilar. And the 13, they are posterior surface of the pancreatic heads, sometimes known as the retroduodenal lymph nodes. And the 14V, along the supramesenteric vein, they are very far distant lymph node. Then stage 15, along the metacollic vessels. Stage 16, the para-aortic lymph nodes. From the diaphragmatic hiatus to the bifurcation of the aorta, 60, A1, A2, B1, B2. So these lymph nodes stage 12 to 16 are tier 3 or far or distant extragastric lymph nodes. So lymph node 1 to 6, the compartment 1, 7 to 11, compartment 2, and 12 to 6, the compartment 3. These are the deep picture also described here 1, 2, 3, A and B, 4, SA, short gastric, SB, 4D, and 5 here, around the right gastric, the 6. This is the first tier. Now 7, left gastric, 8, common hepatic, and 9 is celiac, tier 2. Then 10 is the splenic hyaline, 11P, proximal splenic, 11D, distal splenic, and 12 here is a hepatic hyaline, A artery, P a portal vein, B related to the binder. The 13 is a retro pancreas. 14 SMV. The 16 is para-aortic. So lymph node metastasis depend on depth of the submucosal invasion and the site and region of the tumor. But they are the skid metastasis. And generally, the submucosal invasion up to 300 to 1,000 micrometer. 1,000 micrometer is 1 millimeter. At that invasion, there is about 20% of the lymph node involvement, but mainly to the perigastric lymph node. Only 20% go to the extragastric lymph nodes. But if the invasion is more than 1 millimeter, that means 1,000 micrometer, there is a perigastric and extragastric involvement is quite the same. That depending on the region and the above that tumor here, above that tumors, usually they have a nodal metastasis is 65 to 80% if the advanced gastric cancer, but maybe early gastric cancer, they be 2 to 50%. They involve station 1 here, station 2, station 3, and station 7, 9, and 10. And it's very highlighted, especially tumor located at the greater curvature of the posterior wall. And the mediator tumor usually involve the station 1, station 3, station 4, and station 6, and 7. Sometimes the stages 10 and 16, they are less frequently involved. For the lower third tumor, they frequently involve the 3, 4, 6, then 7, 8, 9. Sometimes they involve in the stage 14 SMV group. So this is a lymph node area depending on the tumor sites. They are very generally speaking, but they are skid metastasis. They can spread to distant lymphatic station, but frequently they involve the leg gastric, common hepatic, and celiac trend 7, 8, 9. So they without involving the perigastric, they can reach to tier 2 or tier 3, about 5 to 40%. So I want to include my topic, lymph node anatomy, but I don't want to mention here because the next speaker will mention about the lymph nodes into the end station and some lymph node involvement in the nodal dissection and D1 or D2. So my topic is quite a basic anatomy topic. So lymph node is very important. So we must know about the thorough anatomy of the lymph node station sites and relation to the vascular supply, so we can do the correct lymph adenectomy. Thank you very much. This is my reference.
Thank you very much, Dr. Aiman.
Yeah.
Am I audible, sir?
Yes.
So that was actually a very exhaustive and elucidative description of the lymph nodal stations, the lymph nodes, the number of lymph nodes. That can be really maximum we can see in the anatomy book around the stomach. And it's so important to select the proper group of lymph nodes and the number of lymph nodes depending on the situation of the tumor in the stomach. That's what you said. And now that we are, so it is also important if you could highlight a little bit it's not that the berry picking of the lymph nodes while doing cancer surgery is actually the lymph nodal removal. It has to be a little bit lymphovascular tissue, isn't it? And we should know the proper plane of removal of the lymph nodes, whether it should be very close to the capsule, whether a little bit away from the capsule, include the fascia of the lymph node. That's what has been also explained by the Japanese group very well. Now that we are, if you want, you can give us some idea about the technique of lymph node removal in these patients, depending on the guided by the anatomy of the surgical anatomy of the lymph nodes. If you want, Dr. Aiman.
Yeah, I'm just basically and principally the lymph node removal. If it is depend on the D1 or D2, but I don't mention D2 here. But if the tumor involve the lymph node, that is perigastric tier 1, we should remove the tier 2 group, basically. If it is a tumor is spread to the tier 2 group, that is the celiac, so left gastric or hepatic, we need to remove the beyond that level. That is a tier 3. But there is some study, they're not very sure about the benefit of the tier 3 removal. I'm not sure about the data. But general principle, we should remove. If it is an involvement, lymph node involvement N1, we remove the N2. So this is a very, very basic principle, as I know.
Yeah, I basically wanted to ask you that we will discuss tomorrow. But
Yeah.
what I wanted to know is it just berry picking of the lymph nodes, pick and pluck of the lymph nodes while you are doing the gastric surgery, or you should get some idea about the lymphovascular clearance, so the lymphatic the fat and the tissue clearance along with the lymph nodes that we say as en bloc during the
Yep.
surgery.
Yeah,
So
sure.
do you have any tip, trick of the trade?
Uh,
Any trick, anything we keep
no,
in
no,
mind while doing the
no.
removal of
No
the
more
lymph
trick,
nodes?
no more trick. Yeah, just to remove as far as possible the M block. Yeah, that's a good idea, but not as if possible. Don't touch technique, especially because lymphatic spillage is very common. And if it possible, we use clip-in. But generally, in our country, we are still using some tie, suture. But if it is, we can use some clip and some uh, very good hemostatic is better because the lymphatic spillage is very very common. I think.
Anything to do, anything to prevent lymphoria in the
Yeah,
post-operative period when we are doing so much extensive lymph nodal surgery?
yeah, sure.
So which energy source you would like while removing the lymph nodes? What energy source you use? Some people they cut it and then do hemostasis. Some people go on cutting through by scissors. Some people prefer harmony scalpel. Some people prefer their diathermy energy.
Yeah. I
Any
think
particular?
I prefer the harmonisca base. I think prefer here. Yeah.
Maybe we
Okay.
will
Okay.
more
With
of
it.
tomorrow's session. And I would also
Yes.
like to introduce two more panelists who have joined. Dr. Sadaf Ali. She is the Chief of GI Surgery at SKIMS in Srinagar. And in between, I saw Dr. Subramanieshwar also joining, although they are panelists for tomorrow, but please welcome them. Yeah, Das, please carry.
So is it my computer that is causing problem or what? I'm
Yeah,
listening to
we are
one
not
side by
getting any
side.
background. I'm not getting any background.
No, I sent you a video. I sent you a video of that. There's
Yes.
another YouTube channel running in the background. Is it with others' computer or mine? If that is the thing, then I will just leave for some time and then rejoin.
Yes. Maybe you
So
introduce the next speaker,
yes.
and then you can log out and
So
log in again.
okay. Now that we are acquainted with the surgical anatomy, the lymph nodal part of the stomach, and we are more or less also we learned about the vascular supply, the parts of the stomach draining to a particular group of lymph nodes from Dr. Aimon. And the next thing we should know is about the etiology of this of gastric cancer, which is I think it's not a part of it. If anyone is covering in part, then it's fine. But the more or less this the etiology of the stomach is no more debatable. And I would say that only one thing that more and more the H. pylori infection, the eradication of the H. pylori infection has definitely reduced the incidence of the cancer. And the other etiology are more or less standardized, and it's according to the incidence of the stomach, varies globally also. So with that, we would move to the diagnosis and diagnosis of gastric cancer. For that, I would like to invite Dr. Nisar Hamdani from Kashmir, sir.
Thank you, sir.
So it's from GMC Kashmir. That is Government Medical College Kashmir.
Yeah, exactly. Government Medical College, Srinagar, Kashmir.
Yes, and I have heard about this topic from you also earlier on.
Right, sir.
So you are getting more and more experience with this. So
Yes, sir.
please go ahead and give your talk.
Thank you, sir. How do I share the screen? Hemant, I'm not able to share the screen. Just a second, sir. I'm just trying to share the screen.
Yes, please.
Hemant, come. How do you share the screen here? Did it here? So is my screen visible?
No. Just please look at the down part of the screen. You will find share screen in green.
Okay.
They're at the bottom.
Yes, it's
at the
not
bottom.
getting actually highlighted, sir. This is
If you put your cursor at the bottom of the
yes.
screen, then they will appear.
That's my screen only. Let's see. So is it visible?
Yes, it's coming. I think it will be visible. Yes.
Thank you, sir. So
Now,
good
yes,
evening, everyone.
yes,
Yeah.
we are there. Yes.
So I'll be discussing investigations in carcinoma stomach, diagnosis and staging. For the sake of ease, I outlined them investigations for the diagnosis of gastric cancer, investigations for staging of gastric cancer, and for further understanding of the disease, which are mainly used in clinical trials. Baseline in is just an outline of the investigations. I'll be discussing them with each slide. To start with, thorough general physical examination and nutritional assessment forms a very, very important part of the basic evaluation of the patient suffering from gastric cancer. After this, we move to the baseline investigations. Baseline investigations, we have same protocol for almost all diseases, but mentioning them and doing them with diligence, with an idea to find out whatever positive findings we can find in them and then appropriately correct them. Like we have anemia, we need to correct it. We have a patch on chest X-ray, we need to evaluate it. We have a chest ECG or an echo abnormality, we must seek a cardiac consultation and do the optimization and risk stratification accordingly, because that is definitely going to affect our overall management of the gastric cancer patient. Then a diagnosis of gastric cancer is mainly dependent on upper GI endoscopy along with its histological assessment. Upper GI endoscopy provides anatomical localization of the primary tumor. It helps us to get the tissue diagnosis. It identifies the partial or complete gastric outlet obstruction if it is present. And if there's involvement of the distal esophagus in the proximal gastric lesions or duodenum in the distal gastric lesions. It also helps us to negotiate the obstruction and place an NG tube or an NJ tube or help us in palliative stenting. The typical appearance of gastric cancer is a friable ulcerated mass. But we must note that in patients with linitis plastica, gastric mucosa may appear normal. There will be infiltration of the submucosa and muscularis propria. There is an extensive submucosal spread. It is usually difficult to pick up endoscopically, and they form the non-diagnostic upper GI endoscopy fractions in the gastric cancer. There may be even no superficial mucosal findings. The only positive finding on endoscopic evaluation will be poor distensibility of the stomach. The common endoscopy, white light endoscopy, what we call, we find there might be color change in the mucosa. There is loss of visibility of the underlying submucosal vessels, and there may be thinning or interruption of the mucosal folds, and the mucosa might be easily bleeding. Endoscopic classification of gastric cancer is basically based on Borman classification, which is classified in 4 groups. We may have a polypoidal lesion, an ulcerating lesion, an ulcero-infiltrative lesion, or an infiltrating lesion, which is often called linitis plastica. Then Japanese have provided us with another macroscopic classification, which is specific for early gastric cancer, where we have a protruted type or a superficial type and an excavated type. This is the endoscopic picture of this early gastric cancer. This is the protruding type, Japanese protruding type of gastric cancer. This is the superficial elevated type. This you can discern here, the flat type, and this is the superficial but depressed type of gastric cancer. And this is the excavated type of gastric cancer. So biopsy is very, very important to confirm the diagnosis and get the histological assessment. All suspicious appearing gastric lesions or ulcerations should be biopsied. Up to 5% of malignant ulcers may appear benign grossly. So if we have an ulcer or an ulcerative proliferative mass, punch biopsy by forceps with sampling from the edges of the ulcer is very important. A single biopsy has a 70% sensitivity for diagnosing an existing gastric cancer, while performing 6 to 7 biopsies from the ulcer margin and base increases the sensitivity to greater than 98%. So multiple biopsies are very important. In diffuse type of gastric cancer, a linitis plastica, leather bottle stomach, stripe and bite techniques are important because these tumors tend to infiltrate the submucosa and muscularis propria. Superficial mucosal biopsies may be falsely negative. For this reason, the combination of strip and bite techniques are very useful. If the ulcer is bleeding, then brush biopsy of the ulcer base will be helpful. The risk of bleeding with this technique is negligible and it increases the sensitivity of a single biopsy. If there is a suspicious polyp, a smear biopsy is adequate. There are few additions to these endoscopic techniques which have greatly increased the sensitivity and specificity of upper GI endoscopy. Chromoendoscopy being one, it changes the color of the mucosa, it magnifies the mucosa, and it enhances the surface mucosal pattern, and especially the capillary pattern, which is usually lost in gastric cancers. So this is the chromoendoscopic picture which I have borrowed from a book. They are not my own. And this is showing the chromoendoscopy. See, there is a lesion there which is not easily discernible on endoscopy, conventional endoscopy. But with the chromoendoscopy, it gets prominent here. Similarly, here in this part of this stomach, this lesion is doubtful, but with the chromoendoscopy, it becomes prominent and very much evident. Similarly here, so narrowband imaging is another addition to this endoscopic armamentarium. It uses blue and green narrowband lights, and it differentiates small gastric cancers from gastrites and improves the margin determination capabilities for endoscopic therapy. It has greatly increased the accuracy, especially in early lesions, and it helps us to magnify the tissue pattern. For staging of gastric cancer, so that it guides us to the therapy and it also helps us to predict the outcome, we have to understand that the primary aim of doing these investigations is actually to stage the disease. AJCC classification, AJCC staging, and Japanese staging are the established staging systems. But for practical reasons, we intend to do is do the clinical staging of the disease. The prognosis is primarily dependent on the surgical pathology, which will define the AJCC and further treatment. But the clinical stage will direct the initial approach to the therapy. So the clinical staging would be early gastric cancers, even with or without lymph node stage, and localized, locoregional resectable disease, or locally advanced unresectable or advanced stage 4 disease. The goal of the staging evaluation is to stratify patients into clinical groups in order to guide the management. Locoregional or potentially resectable, and locally advanced unresectable or metastatic disease. The ultimate choice of staging modality is dependent on the clinical scenario and local expertise and availability of logistics, which are generally consistent with the NCCN or European Society of Medical Oncology guidelines. After confirming this gastric cancer, first modality, preferable modality would be a ultrasonography of the whole abdomen and pelvis. Advantages are evident. It is easily available. It is economical, portable, can be done on the bedside patient who is moribund and not mobile. It picks up ascites, liver metastasis, pelvic deposits. It can even pick up the thickening of the stomach wall and enlarged nodes. So it can also help us to get a USG guided FNA of liver metastasis or ascites for cytology. And it may be the only investigation needed after confirming a metastatic disease, especially in patients with poor performance status and significant comorbidities who are candidates for supportive care only. They need not to go under further investigations, aggressive investigations. Then computer tomography scan, contrast enhances chest CT, contrast enhances CT of chest, abdomen and pelvis. Typically with oral and IV contrast is needed in almost all patients, except for the small fraction which I discussed earlier. And the advantages are that it is easily available, and there's a surgeon comfort with CT. It is more anatomical, and it's less invasive, rather non-invasive. It identifies a widely metastatic disease, especially hepatic or adnexal metastasis, ascites, or even distant nodal metastasis. It can avoid unnecessary surgery, although biopsy confirmation is still recommended. Disadvantages with CT scan are that peritoneal metastasis and hematogenous metastasis smaller than 5 millimeters are frequently missed by CT. And in 20 to 30% of patients with negative CT, intraperitoneal disease, including positive peritoneal washings, will be found either at staging laparoscopy or exploratory laparotomy. With T-stage, it is less accurate for assessing the depth of primary tumor invasion, particularly with small tumors or early gastric cancers and the presence of lymph node involvement in such tumors. It assesses the T-stage of the primary tumor in only 50 to 70% of cases, typically for more advanced cases and not for early diseases. More often, the tumor is understaged because of the depth of the invasion is underestimated. Sensitivity of CT scan for detecting regional nodes is limited for involved nodes that are smaller than 0.5 to 0.8 centimeters. False positive findings may be attributed to inflammatory lymphadenopathy, and CECT accuracy for regional lymph node metastasis in gastric cancers or G-junction cancers is 65 to 97% sensitivity and 50 to 90% specificity. Regarding MRI versus CT scan, MRI has been found to be superior in T staging and superior in or non-inferior in N staging compared with contrast-enhanced CT scan for patients with gastric cancer. In a recent study published in Radiology in July 2024, MRI was found to have more accuracy for T and N as compared to CT scan. MRI was superior for staging T1 and T4A lesions and N1 and N3 tumors. Endoscopic ultrasound is effective for evaluating the depth of gastric cancer, which is the most reliable method to evaluate the depth of the gastric cancer. It is recommended by both NCCN and ESMO for pre-treatment evaluation of all those patients of gastric cancers who have no radiographic evidence of metastatic disease and have otherwise potentially operable disease. Accurate assessment of T and N stage is very important for treatment selection, and it is a procedure with very low complications. The risk of serious complications is less than 0.3%, and that is seen mostly in the settings of obstructed G-junction tumors. Accuracy of EUS in detecting T1, T2 lesions were near about 85 to 90% respectively, and for T3, T4 lesions was 86 to 90% respectively. It can detect nodes in 83 to 67% patients. The heterogeneity can be explained partly by the degree of variability in operator expertise, but EUS cannot alone be considered optimal for distinguishing positive from negative lymph node status. EUS is better than CT at assessing tumor depth, that is T stage, and perhaps lymph node involvement, particularly if FNA aspiration is also performed. The problem with EUS is that it is not uniformly available with surgeons, and it is highly operator dependent. PET-CT. PET-CT, initially it was used non-selectively in the earlier years of its introduction into the medical system. And now with the high quality of contrast-enhanced CT imaging, we have been finding decreasing yield with the expanded use of PET-CT. Presently, NCCN and ESMO guidelines recommend selective use of PET-CT in patients who have equivocal findings on CT imaging or patients with clinical indications of possible metastatic disease and otherwise negative imaging. PET-CT is more sensitive than conventional CT for detection of distant metastasis. And from the standpoint of loco-regional staging, integrated PET-CT imaging can be useful to confirm malignant involvement of CT-detected lymphadenopathy. However, this usually does not impact the decision to proceed to surgery. The disadvantage here with PET-CT is that many lymph node enlargements in our setting, Indian settings, they may be inflammatory, may be tubercular, and they may be falsely identified as malignant lymph nodes. Besides that, limitations of FDG PET in peritoneal carcinomatosis, the sensitivity is only 50%. It is not an adequate replacement for staging laparoscopy. And there are some non-FDG tumors, especially diffuse type of gastric cancers, and where peritoneum is the most common site of metastasis. A negative PET is therefore not helpful, since even large tumors with diameter of several centimeters can be falsely negative if the tumor cells have a fairly low metabolic activity or are not FDG avid. This is a FDG PET picture of a diffuse gastric cell carcinoma. You can see thickened stomach wall, uniformly thickened stomach wall, and there's irregular mucosa also, the stomach. The acceptable thickness of stomach is 8 millimeters in a non-distended stomach. And here we can see this faintly avid FDG avid stomach wall. Staging laparoscopy with peritoneal washings. This is done in patients who appear to have more than T1A lesion on preoperative workup on CT or EUS wherever it is available in any medically fit patient. And these constitute most of our patients, in fact, in clinical practice. This approach is consistent with NCCN guidelines but differs slightly from ESMO guidelines, who suggest staging laparoscopy for more than T2 lesions. So, and especially when neoadjuvant therapy is planned, staging laparoscopy is very much needed. It is not useful in patients with clinical and or histological confirmation of advanced stage 4 disease. And it's also not needed in patients who require palliative surgery or gastrectomy for their symptoms. The advantages of staging laparoscopy are that it detects occult peritoneal dissemination, and sensitivity of PET for detection of peritoneal metastasis is only 50%. And sensitivity of staging laparoscopy has been reported up to 90%, which is greatly added by the cytology studies. It has staging laparoscopy has particularly high yields in patients with signal cell carcinoma, linitis plastica, that is diffuse gastric cancer, and the sensitivity decreases, yield decreases with decreasing T. T4 has more pickup rates than T3 than T2, and it can be up to 50% in patients with advanced disease. Staging laparoscopy avoids unnecessary laparotomy and it decreases the morbidity. It directly visualizes the liver surface and peritoneum and can be used to examine local lymph nodes also, or even sample them for frozen sections. Advantage of laparoscopy is the opportunity to perform peritoneal cytology or washings in patients who have no visible evidence of peritoneal spread. So there is lower morbidity of laparoscopy or exploratory laparotomy. Disadvantage as compared to CT and US is that it is more invasive. So investigations regarding genetic testing in gastric cancer. Just a brief idea, gastric cancers are in 90% of patients, they are sporadic. Only 10% have familial gastric cancers, but truly hereditary gastric cancers account for almost 1 to 3% of the global burden of gastric cancer. And there are 3 major syndromes. One is hereditary diffuse gastric cancer, and there is gastric adenocarcinoma and proximal polyposis of the stomach, and familial intestinal gastric cancer. The risk of developing gastric cancer is high in these families, but only hereditary diffuse gastric cancer is genetically explainable at present. So International Gastric Cancer Linkage Consortium guidelines recommend a referral for genetic counseling and DNA testing for cadherin-1 mutations in patients with diffuse gastric cancer who have one or more of the following: diffuse gastric cancer diagnosed at age less than 40 years, regardless of the family history of 2 gastric cancers at any age with at least 1 confirmed diffuse gastric cancer, family or personal history of diffuse gastric cancer, and lobular breast cancer with at least 1 diagnosed at less than 50 years of age. The latest International Gastric Cancer Linkage Consortium guidelines were revised in June 2024, but to my knowledge have not been published as yet, but the last published guidelines were in 2020. Patients treated for gastric cancer should also be tested for Helicobacter pylori. It's a major risk for gastric cancer and is associated with development of metachronous gastric cancers. All gastric cancer patients should be screened for H. pylori and treated if positive, at least in the setting of early gastric cancer or even after once we have done a gastrectomy. Patients who undergo total gastrectomy, they are not susceptible because there is no gastric mucosa left. But if you have done a partial gastrectomy, distal, subtotal, then these patients should be treated with for their Helicobacter pylori. Regarding serological markers, they have low rates of sensitivity and specificity. They have limited utility in selected patients, and they cannot be used as diagnostic or screening tests for gastric cancer. Clinical decisions are almost never made based on tumor marker change alone. No serological findings should be used to exclude a patient from surgical consideration. And NCCN guidelines do not include assay of any tumor marker at present. Serum CEA, CA125, CA199, CA72-4 may or may not be elevated in patients with gastric cancer. Alpha-fetoprotein may be elevated in some gastric cancers, the hepatoid adenocarcinoma of the stomach variant, and AFP-producing gastric cancer are aggressive and usually associated with a poor prognosis. Pepsinogen has been used for population screening programs to identify patients at increased risk for gastric cancer, but they are insufficiently sensitive or specific to establish a diagnosis in an individual patient. Thank you.
Thank you very much. Actually, I must admit that the investigations and diagnosis of stomach cancer itself is such a vast subject now that the entire session could be devoted to it. And you have very nicely and in a concise manner presented it. Thank you for that. Now, till we get some questions, I can't see anything here. So can I discuss some points with you?
Yeah, Das, please generate questions, and I request the other panelists also to chip in. Questions related to Nisar's presentation can be taken now, and then we have half an hour for open house session, whatever has not been covered.
Yeah, that's what I have asked. I want to request the panelists to ask questions. I can't see that in the chart.
They will not come in our chat. They will come in YouTube chat, which the Avinash Tan's team will convey to me, and then I will post it.
Okay. So questions from the panelists, please.
Yes. Panelists can make comments and questions. You generate discussion.
So till I find that, can we? Yes, I want to ask. Start the discussion by just starting mostly for the students. How important it is to get a good history and physical examination in the management or diagnosis of the gastric cancer.
Sir, the question is to me?
Yes.
Yeah. History and physical examination, they form the cornerstone for management of any surgical or medical case, no doubt. And regarding those patients who have to undergo a massive surgery and a significant post-operative therapy, definitely it can change the course of the management. History taking, especially in carcinoma stomach, diagnosis, I won't say it adds much to the diagnosis. There has to be a high degree of suspicion and more and more screening and early endoscopies. But definitely, a history suggestive of early satiety, a history suggestive of vomiting, that points us towards the gastric outlet obstruction. Dysphagia, that points out towards the GE junction obstruction, and history of weight loss, that points us towards the metastatic nature of the disease. And in examination, if there's a lymphadenopathy, peripheral, clinically palpable peripheral lymphadenopathy, that points out towards the metastatic nature of the disease. Or if there is icterus, if there is visible icterus, there may be a lymphadenopathy or the tumor infiltrating the HDL or the hilar nodes, and then ascites, then the per rectal examination, digital rectal examination, that can definitely add to our understanding. Maybe there are pelvic deposits in this particular patient. No, that's it.
For the sake of students, I may add, Das, that CA stomach, one has to carefully examine, as Nisar said, the neck, and I would add that even the axilla, CA stomach is known to metastasize to axillary nodes also. So,
yes, sir.
Very careful clinical examination, especially in advanced cases, which most of our patients are, is very, very important.
So is it important, so important to consider the family history in these patients nowadays?
Family history,
like colorectal cancer.
So family history, definitely it should be asked, and especially in those patients who are young patients, they tend to have familial this gastric cancer. But exactly, to be very honest, in the rush of managing patients, we do not usually give much importance to those aspects of the disease management.
So when would we advise a patient to get the genetic testing done? I know it's a gray area, the family history, because only particularly one syndrome that we can exactly say that is hereditary, which concerns the CA stomach.
Right.
But when to get the genetic testing done, these patients, particularly in Indian scenario, because these are very costly also. They
are very costly tests, definitely. I would say that those patients, number one, who present in early age, who are young, who have a family history of GI malignancy or breast malignancy or thyroid malignancies, and that's it. I won't add much.
I think for the students, I think it is important that it's not we are yet to get the entire profile of genetic markers for like any other cancer. For the gastric cancer also, possibly the minimum. And it's not necessary that if we do not get any particular gene or so, that the patient will not have any cancer. We can't say that in future. So you have to say that if you are getting this genetic testing done, if it is negative or in the profile it is not coming, still you have a chance of getting cancer in the course if you have a family history.
Nice.
Now, before going into the next question, I would give you a very interesting data that is from Japan. Since they have started this early gastric cancer screening and detecting this stomach cancer quite in early stage, they have increased the survival from 5% to 50%. So it's so important for incidental for the early gastric cancer to be detected. So what is the situation in India? That whether from the history we can think of that this guy might be having early gastric cancer, and if that, then when to expose the person to endoscopy with a suspicion of malignancy?
Oh, I don't have. I'm not getting the question, sir.
So can we from the history or examination, not from the examination, obviously from the history, think that this person might be having early gastric cancer, or from which symptoms we would say that this patient should go for endoscopy?
Based on symptoms, if patient is having some some acid peptic disease, if there is change in the nature of the symptoms, definitely that should raise the suspicion. If there is any melena, or that will suggest there has been a GI bleed or anemia, or if there is new onset symptoms which are not initially present there. But still saying that still patients with early gastric cancer usually do not have prominent or significant symptoms. A high degree of suspicion and overindulgence into diagnostic, the screening endoscopy, definitely I would recommend.
Any other opinion from the panelists, please, or Kapoor sir?
Yeah, that's one point I wanted Nisar to clarify, because it is still mentioned in some books, and students are often asked this, the myth that if a palpable lump is there in CA stomach, it is unresectable. Would you like to respond to that?
Yes. I was just going to ask that question. We were taught about the 4 A's the diagnosis of gastric cancer. One of them was a lump. If it is there, it was unresectable. That is not the case now, of course.
Yes, definitely, sir. A patient with gastric cancer having a lump is more likely to be unresectable, but it does not confirm that it is unresectable. It can still be a resectable lesion. That patient is more likely to be unresectable because with expanding indications, with multivisceral resections, definitely, but proved that we have that patient is having a PET documented non-metastatic disease, we can go ahead with local resection of adjacent organs. In our own experience here, because we're seeing good number of gastric cancers in our setup, it is a government medical college setup. In past 5 years, we had done almost 7 patients in whom we did pancreaticoduodenectomy for locally advanced gastric cancer, only locally infiltrating into pancreas. But patient had received neoadjuvant chemotherapy and PET documented non-metastatic disease. And out of those 7, 5 are on our follow-up. We have lost 2 patients, but 5 are still on our follow-up. So lump per se is not a contraindication, but definitely it points towards the more advanced disease.
Hamza, you wanted to say something? Yeah, Hamza and then Sadaf.
Yeah, sir, as the Japanese have proven in their robust screening program along with Korea, I think the key to identifying early gastric lesions lies in robust endoscopy rather than genetic testing. The road is ahead of us. That has been laid out well by these 2 examples in front of us. But the key here is to identify high risk and high epidemiologically high incidence areas. We have, like in our part of the country, in Kashmir, and especially in southern Kashmir, we have found a higher incidence of these gastric malignancies, and more so with proximal lesions. So we could identify patients based on environmental risk factors. Those having chronic GERD or dyspeptic symptoms could be subjected to endoscopy after a certain age. So the need of a screening program in a high-risk identified area could be the first step, because endoscopy in our setting is not that expensive.
So for students and surgeons who have joined from other parts of the country and abroad, the one region where incidence of carcinoma stomach is high is Kashmir, and that is why we have such a strong representation of panelists from the states of Jammu and Kashmir. TS, you came in, you want to say something?
Yeah, sir, I wanted to make the same point.
Sadaf first and then Subramanyeshwar.
Yeah, I wanted to make the same point that it has to be like we have the gallbladder cancer is dominant in some belt. Gastric cancer is again dominant in this part of country. So our threshold to do upper GI endoscopy should be a little low. And those who are pointing towards some symptoms, as he mentioned, and to add to it an age group which is beyond 40s or 50s, the threshold should be low and we can pick up early. And so you made a point about palpable gastric mass. So the advanced subset of the patient now are not those kind of neglected subset of the patient. And we need to, I wanted to know from Nisar that whether second line drugs and what are the concepts of HER2 receptors and the PL and the mismatch, as in colonic cancer and other cancers that are coming up. So in workup status, whether there's a space for patients who have advanced disease. and you want to be, they have good performance, and when you want to be aggressive in their treatment with a neoadjuvant approach.
Before Nisar answers that, and lest I forget, I would request Sadaf, Nisar, and Hamza to please come together, get more people involved, and think about this, that is a screening of at least high risk, not population, high risk individuals in the state of Jammu and Kashmir, collect some data on incidence, get some information from the Japanese and Korean programs. I will try to connect, you create a small group of you people. I will try to connect you to somebody in Japan and Korea through Supermanation also. He has a lot of contacts with people who have interest in CS stomach. And I think we should take people like Supermanation and others who are interested in CS stomach down south and start this at least thought process that do we need some kind of a selected screening program for CS stomach, at least in some parts of our country. So just a food for thought. Nisar, please answer, and then TS can come.
Yes. Hello, ma'am. Regarding this, these tests for HER2/neu and other tests, they definitely have a space in metastatic gastric cancers, and they are done if there is affordability or there is that patient support program is providing that that scope of doing those tests. And for these metastatic gastric cancers, besides that first line FOLFOX regime, what I've seen here from my medical oncologist colleagues, because it's not a purely my domain, but I've seen got this information, what I see in my patients. They ask for HER2/neu this testing, and if it is positive, then they definitely put on those patients on trastuzumab. They do PD-L1 testing. If CPS score is more than 5, they do use that nivolumab, or if it is more than 10, then one more drug is that panmozolimab. I'm not able to pronounce it properly. Sorry for that.
You can say Zilumab and
but it starts with Panzo. That is
so that is chipping in, and within the era of D3 and metastatic disease being treated more.
And besides, they are doing MSA testing.
But the performance status has to be good. Definitely, the bottom line comes over there.
Yes, and most of the times, ma'am, but issue is regarding the financial aspect of that. The therapy is quite costly. Only few patients I've seen taking that medicine with compliance. I think I can add that much only.
Yeah, that's what just to generate.
Thank you.
Yeah, Subramanian, you wanted to say something. Please.
Thank you very much, Kapoor sir, for having me in this very intelligent and elite panel. Regarding the lump, I have a few thoughts that I would want to share. You have different morphological forms of cancer of the stomach. Lump would always talk about advanced cancer, but it would always be better to have a proliferative type of a disease in the antrum of the stomach rather than a linitis plastica without a lump, wherein you don't feel anything, but you have practically lost the battle in most of the patients in a linitis plastica. So a proliferative or an ulcerative proliferative lesion, morphological lesion, even if it is producing a lump or if it is producing an obstruction, is much better biologically than the diffuse infiltrative type of because most of the time palpable lumps, not the palpable stomach, but palpable lump actually represents the intestinal type of stomach cancer. Although it is advanced, it's not as bad as linitis plastica or the diffuse type of gastric cancers. That is one aspect. And then I think oncology itself is going the molecular way now. We have talked about histology, histomorphology, cross morphology, microscopic, but now I think treatment-wise, it's going to go molecular. Breast has completely become molecular. We don't talk about infiltrated duct cell carcinoma, NOS, or otherwise now. We talk about molecular subtypes. Endometrium is completely treated, at least the adjuvant therapy. Surgery has not changed, but adjuvant therapy is all molecular. Similarly, stomach also, I think, is the next organ which is going to go molecular. Dr. Nisar has clearly told you that in metastatic setting, there is a clear role for all these tests. But I think slowly it will come into adjuvant and probably rule as more and more targeted therapies and immunotherapy is added into the armamentarium. I think it will become molecular. And we hope to stay alive to see that true personalized medicine comes into cancer stomach treatment also. That's all from me, sir. Thank you.
Thank you. Thank you.
So,
I think
so
we
if-
can proceed, Das, unless you want to add something.
I would add some few lines to that, what we are already discussed, my own experience. Now, we have conducted camps under the leadership of Professor Anup Sarai, who used to be HOD here. We did it in Ladakh, we did in Assam, northeast areas, and also my home state in Odisha. And we find lots of cases of gastric cancers. So definitely those are the areas where I think the high incidence areas, they have to be explored, and they should be looked for early gastric cancer to increase the survival in that population. Second thing is regarding this molecular treatment in form of the MABs, the monoclonal antibodies. I have been a part of the famous TOGA trial published in Lancet, and that's regarding that trastuzumab. And after that, in that we only provided 3 cases. I only provided 3 cases in that trial. It was so rare at that point of time. But following that, actually, my own experience of these molecular things, particularly in gastric cancer, never been very satisfactory, and these are very costly also. And these trials are going on in Japan. Maybe at the end of this year, we'll get some answers from them. Yes, there is a definite future for this. Now, third and last thing which I wanted to say is this PET scan. Now, in many fora, people have agreed that there is a overuse of PET scan in the diagnosis and treatment of stomach cancer. This is for the students. PET scan is not a very safe investigation. It involves radiation, and it has its own side effects, and it is very costly. So before using it, we have to be very judicious in its use, and you must know that PET scan, the size of the tumor detected in PET scan is almost equal to size of the tumor detected in the CT scan. So that's what I wanted to say. And if any other panelists don't have to say anything, then we would move forward to the next session, the next talk.
Yeah, let's move on.
So they now that brings us to the management aspects, and we will be mostly dealing with that tomorrow. And all of us know that the cornerstone of management in stomach cancer is surgery, and even nowadays, majority of the Japanese surgeons, they would agree, they would prefer to go for surgical management, even if it is advanced stomach cancer. In this way, they little bit differ from the European group. And they are doing their own trials now in Japan, and almost at the end of the trials to decide whether adjuvant perioperative chemotherapy, which is a norm in European subjects, now is it true for Japanese or not? So surgery is still the main part in the management of stomach cancer, and in different surgical procedures, the basic is the gastrectomy, the resections of the stomach in different forms depending on the situation or the extent of the disease. And like any other surgery in GI tract, there is a debate regarding the minimally invasive versus the open surgery. Slowly and steadily, and I must agree that minimal invasive surgery is taking over in many areas in the management of GI tract cancers, and stomach cancer would be one of them. So now we would only discuss about the minimal invasive surgery related to gastrectomy per se. And I think I'm not very sure whether he would deal with Dr. Hamza Wani from GMC Jammu, the other part of the Jammu Kashmir. He would be discussing about the minimal invasive surgery, minimal invasive gastrectomies. Possibly he would be covering the benign or malignant, and if he only covers the malignant part also, it's okay. So Dr. Hamza Wani, please continue. talk.
Thank you very much, sir.
Before Hamza starts, I forgot to mention, I'm sure Das may have mentioned, Nisar also is our former fellow from SGPGI.
Yes, yes.
And I'm very happy to see Das and Nisar, they are the first generation fellows. I'm very happy to see the second generation of fellows now, because Hamza has done his fellowship with Dr. Ibrar, who was our fellow in SGPGI. So I welcome the second generation, the grand fellows now to masterclass. Hamza, please.
Thank you. Thank you very much, sir. Very kind of you. I'm probably the junior most colleague over here. So
Youngest.
I would like to...
Don't say junior most, youngest, most energetic.
Thank you, sir. So the ambit that was given to me was minimally invasive techniques for gastrectomy. And sir told me to focus on the literature and the current status of gastric carcinoma. So I'll be focusing on the malignant disease itself. So is my screen visible, sir?
Yes.
Yeah. So just an overview, we know that CS stomach is the 5th most commonly detected malignancy and 3rd largest cause of cancer-related death. Like we discussed before, it is one of the 3 largest burdens of malignancy in our region, that especially the Kashmir division of the state. Now, when we look further east, the other part of the coin is the Southeast Asian countries, particularly Korea and Japan, having a robust screening programs detect early gastric carcinoma, and it takes about 61% of their diagnosed burden. And the majority of our cases are detected at stage 3 onwards, and stage 2 if we are very lucky. So talking about adenocarcinoma of the stomach, there are 3 main determinants of the disease. First is the stage, then the general condition of the patient, the performance status, as well as any comorbidities, and the tumor location. Why do we talk about the tumor location? And this is because it actually determines the kind of surgery your patient is going to have. For adenocarcinoma of the distal and middle third of the stomach, you would have to subject the patient to something of a subtotal or a distal gastrectomy with any reconstruction, any variation of the Billrod 2 or a Roux-en-Y gastric anastomosis as per the surgeon's choice. For proximal lesions, those having linitis plastica, polydifferentiated tumors of the diffuse variant, total gastrectomy is the procedure of choice, and a reconstruction will entail an esophagogynostomy Roux-en-Y. It is important to mention because when we talk about minimally invasive surgery, these are the techniques and the procedures that you need to replicate in the OR. The next most important part of the gastric resection is the lymphadenectomy. I won't go much into it. It will be discussed tomorrow. But we need to map the route to R0. And the Japanese Research Society for Gastric Cancer has been telling us from the 70s about the nodal stations from 1 to 12, which are relevant in gastric carcinoma. And how do we talk about D1, D1 plus, and D2? What to do when and how. But I'd like to specify here that it does affect disease specific and overall survival. So it is a very important part of our surgical practice. Now, particularly talking about minimally invasive gastric surgery, if we talk about a lesion in the distal or middle third of the stomach, the specimen inside would look something like this. Once we enter the lesser sac, retract the stomach cranially, the stations labeled in blue would entail a D1 block. Once, if we include 8A and 9, would be a D1 plus. And if we take the proximal sphenic artery nodes and the proper hepatic artery nodes, it would be a D2 resection. So this is just to give an idea that where do we need to go and where from the pedicles need to be taken in the view of a minimally invasive scenario. Also, when we talk about minimally invasive surgery, the concept of the mesogastrium that came from China and dissection in the enjoyable embryological space, as Dr. Das sir was making a comment earlier, where do we need to dissect? So there are 6 main mesogastric pedicles that have been described, anatomic pedicles. They are the left and the right gastroepiploic mesogastrium, the left and the right gastric artery arterial mesogastriums, and the posterior gastric mesogastrium that is along the sphenic artery. So by a combination of exposure, traction and counter traction, separation of the embryological planes, dissection at the root, and ligation at the root, we can actually get rid of the lymph node block along with the lymphovascular components along with that. So that would entail the basic principles of a standard gastric D2 resection in a minimally invasive settings. So whenever we do an open radical distal gastrectomy, this is what we are looking at post-dissection. What we want to see is a completely bare tumor bed where you can see the celiac axis, the proximal part of the sphenic artery, the station 8A node taken, the 12A node gone, and ligation of the gastroepiploic vessels at the root at the base of the pancreas. Now, how do you translate this triad into the minimally invasive setting? what we prefer to do and what we have learned is we do the laparoscopic gastrectomy with the surgeon standing in between the split legs of the patient. The assistants can shuffle between right and left depending upon the pedicle you're going for. The monitor is at the head end and the trolley is at the right foot end of the patient. What we want to see is this right here. The clipped root of the right gastric artery over here, the 12A nodes going up, which have been taken. This is the gastroduodenal artery. The station 8A nodes gone, and this multiple clips on the left gastric artery pedicle at the celiac trunk. So the idea of showing this is that you need to replicate your technique that you're doing in your open surgery in the minimally invasive scenario. So those are the 11P nodes right up to the splenic hilum. This is again radical distal gastrectomy, laparoscopical. And the idea is to get a similar outcome as you're doing in your open surgical practice. Now, when we look at the history of minimally invasive surgery, first it was reported from Japan by Professor Kitano's group. They did a Billroth 1 reconstruction, laparoscopy assisted. Then over the next 5 years, it got further evolved into a laparoscopic D2 gastrectomy. And Azagra and colleagues actually in 1999 described a laparoscope-assisted distal and total radical gastrectomy for locally advanced gastric cancer as well. In the early 2000s, Professor Giulianotti's group from Italy described the distal and total robotic radical gastrectomies. So these were the initial steps that actually told us that there was a proof of concept that these techniques could be used to deliver in these settings. And the minimally invasive techniques came with its usual benefits in the short term: low morbidity, early return to work, less requirement of post-op analgesia, less wound-related complications. The flip side in these was that there was a less lymph node retrieval and the operating times were longer. And obviously there was a selection bias. So the conundrum remained that how does it fare? How does minimally invasive surgery fare in an oncological setting? Because we need to deliver a safe and goal-directed treatment option because we're dealing with the cancer and its inherent challenges. And the priority is to deliver a safe procedure as well as an oncologically feasible procedure. And to answer these questions, good quality data focused on those was needed. And that is exactly what we have got over the past 2 decades. Now, we have already talked about the screening programs in Japan and Korea, and most of the data, actually more than 90% has come from there. So looking at the early Japanese data, Professor Katai and his group actually published in 2010. They looked at clinically stage 1 gastric cancer patients, 176 patients, and the idea was to assess safety of laparoscopic assisted distal gastrectomy plus a D1 plus nodal dissection. And they demonstrated the safety of the procedure in the short term. And in 2018, they also published the long-term results and demonstrating an excellent 5-year overall and recurrence-free survival of 98.2%. This was followed up by a more refined, the Japanese clinical oncology group by the same group, and they published the results in 2016. This was a multi-center phase 3 randomized controlled trial. They compared laparoscopic distal gastrectomy versus open against stage clinical 1A and 1B. They had 921 patients, and they reported similar recurrence-free and overall survival in both the groups. Now, keeping up with this trend, the Koreans stepped in with the excellent class 1 study from the Korean group. Professor Kim published in JAMA Oncology in 2019. This is a wonderful study that actually demonstrates safety of laparoscopic distal gastrectomy in early gastric cancer. They accrued 1,416 patients using 15 surgeons, 13 institutes. And when they published their short-term results, they demonstrated statistically significant differences in post-operative morbidity. As far as intra-abdominal complications were concerned, they did demonstrate lower number of intra-abdominal complications in the laparoscopic group, but it did not reach statistical significance. And when they published their long-term results in 2019, the overall survival and the cancer-specific survival almost mirrored each other. And they actually came out and said that when using for stage 1 distal gastric cancer, laparoscopic distal gastrectomy is associated with low morbidity and comparable survival to open, and it does not compromise the oncological outcomes in the long term. And this endorsed the view, and actually the Korean surgical guidelines endorsed laparoscopic distal gastrectomy as a standard treatment for stage 1 gastric cancer, obviously by surgeons with sufficient expertise. Now, they started to stretch their wings a little bit, and they said that what about the technically more demanding total gastrectomy with proximal lesions? Again, here we're talking about early gastric cancer. The part of the Korean class group was the O3 trial, and they published their results in 2019. They looked at laparoscopic total gastrectomy for early gastric cancer for feasibility. It was a single-arm prospective multicenter trial, and it demonstrated a post-operative complication rate of 20.6% and a mortality of 0.6. And when they compared it with their with the studies published in the open category, total gastrectomy was comparable. And another wonderful trial came from China, which again looked at total gastrectomy. It was a multi-center RCT. The Chinese class group, the O2 trial, published in 2020, they compared the safety of laparoscopic total gastrectomy and open total gastrectomy, again for stage 1 gastric carcinoma. And all of these patients showed no significant difference in overall mortality and morbidity. And the post-operative complication rate was extremely comparable. And this study actually sort of solidified the idea that laparoscopic total gastrectomy with lymphadenectomy performed by experienced surgeons is as safe as open total gastrectomy. So we have spoken about early gastric cancer. So is the debate settled for it? Apparently for the Koreans and the Chinese and the Japanese it is. But what about advanced disease? The bulk of our cases, this is the Japanese laparoscopic surgical study group. They looked at 507 locally advanced gastric cancer patients. It was a multi-center open label trial, 37 centers. And they found out that the laparoscopic group had a longer operative time, but significantly lower median blood loss of 30 ml versus 141 ml, which was statistically significant. More importantly, they were able to show the non-inferiority of laparoscopic gastrectomy distal for advanced gastric carcinoma versus an open distal gastrectomy. And the overall survival data also supported the non-inferiority of laparoscopy in this group. Similar trial came from the Korean group, the O2, in the form of the O2 trial, and they looked at 1,050 locally advanced gastric cancers. They classified tumors from clinical stage T2 to T4A. The catch here was that there was a low nodal burden patients, and 37 centers randomized them, and they found out that the laparoscopic distal gastrectomy with D2 lymphadenectomy in locally advanced gastric cancer had lower rates of both early and late complications. And interestingly, the 3 years recurrence-free survival rate was almost mirroring each other, with 80.3% for lap-assisted and 81.3% for open distal gastrectomy. The trial that I liked the most among all of these actually came from China. That was the class 01 trial. This was the first in their class series of trials, and they actually started looking at advanced gastric cancers because the bulk of their cases are advanced cases. And they accrued 1,056 patients, and they looked at clinical stage T2, 3, and T4A. They ruled out bulky nodes, and they actually defined these bulky nodes. They said that any nodal mass that was more than 3 centimeters will be excluded. They published the results in 2022. And when we looked at the survival rates over 60 months for all the stages, it is similar in both the groups, laparoscopic as well as open. And then stage-wise breakdown also showed that the outcomes mirrored one another for stage 1, stage 2, and stage 3. Now, the interesting part in this trial was that if they were reporting about locally advanced gastric cancer, why did they have TNM stage 1 disease, and they reported them in their findings? It was seen that in this study, a lot of cases were actually overstaged at the clinical time, at the clinical stage, and then they became part of the analysis. But notwithstanding that fact, when we looked at it individually at stage 2 and stage 3 patients, the outcomes were almost similar over 60 months. So it again proved oncological feasibility of the procedure. And they came out with this conclusion that when used for advanced gastric cancer, T2 to 4A with a low node burden, the laparoscopic modality is associated with no significant difference in overall 5-year survival versus open distal gastrectomy when performed by experienced surgeons at high volume centers. Now, this term experienced surgeons at high volume centers has come a number of times in all these studies. We need to understand that the identification of centers and surgeons in all of these trials was very stringent, and a lot of peer review and a lot of peer review was done in selecting which surgeon will be doing, which has at least a certain number of procedures under their belt and have a certain number of per annum cases attending the centers. Now, having looked at all this data, there are further questions that remain, especially in our settings and the Western setting. What about proximal tumors? And what about tumors that require neoadjuvant chemotherapy? So looking at the data, there is still a lack of high quality data in clinical research, which focuses just on advanced upper and middle third gastric cancers. There's one trial from Netherlands, which had actually 227 patients, and out of which 102 of them were upper and middle third lesion patients. Across the board, they had anywhere from T1 to T4A and nodes anywhere from N0 to N3B. They showed there was no statistically significant difference in the 3-year prognosis, with the laparoscopic group again showing lower intraoperative blood loss. The Chinese, in the 04 iteration of the class trial, actually looked at proximal tumors with nodes in the splenic hilum, and they compared the conventional laparoscopic total gastrectomy with a variation known as a laparoscopic spleen preserving total gastrectomy with splenic hilar lymphadenopathy. They actually showed the feasibility of this laparoscopic spleen preserving total gastrectomy with splenic hilar lymphadenopathy. And it actually showed favorable long-term outcomes in advanced upper third gastric cancers. The Korean class 06 and the Chinese 07 trials are focused on locally advanced upper and middle third gastric cancer. They started accruing in 2017. They have published their short-term results, and unsurprisingly, the short-term results in the laparoscopic group have been seen to be beneficial. We still await their long-term results, but the expectation is that the long-term results will mirror what we have seen in the studies of the past between both of these groups. And the Chinese class 03 trial is planned to evaluate the safety of laparoscopic gastrectomy after neoadjuvant therapy. In these countries where they have a robust screening protocol for early gastric carcinoma, the question of quality of life actually emerged. Since they are doing laparoscopic gastrectomies for T1 disease or stage 1 diseases, they have looked at other function preserving gastrectomies like pylorus preserving gastrectomies, laparoscopic proximal gastrectomies, vagus preserving gastrectomies. One such trial is the Korean class 04 trial, which looked at laparoscopic distal gastrectomy versus laparoscopic pylorus preserving gastrectomy. They included stage 1 tumors, which were at least 5 centimeters away from the pylorus, and compared them with one another. And both of the procedures actually favored similar. The laparoscopic pylorus preserving group actually compared favorably with the laparoscopic distal gastrectomy group as far as quality of life is concerned. The overwhelming question was whether these patients would actually develop some amount of gastric stasis or gastric outlet obstruction. And it was seen that only 7.5% of the patients in the laparoscopic pylorus preserving group actually developed some amount of gastric stasis or gastric outlet obstruction, and none of them needed a reoperation. So this is where they have reached. They are preserving functions in early gastric carcinoma, and we are still looking at survival and diagnosis of patients before stage 3 and stage 4. So this is just a summary, looking at the short-term oncological outcomes in the large randomized controlled trials. And this is in the advanced gastric cancer setting. Now, a little briefly about robotic surgery, since we don't have much experience with it. It does seem that there is an inevitability about it. Why do I say that? It is because robot-assisted surgery has made significant incursion into various surgical specialties. And it emerged basically as if you want to call it limitations, as a solution to the limitations of laparoscopy. They mentioned 3D imaging, motion scaling, enhanced surgical field visualization, tremor filtering, precise alignment, and articulated wrist joint, and the 7 degrees of freedom as their USPs. And importantly, the design of the surgeon console helps us to sit comfortably, reduce discomfort, fatigue, and burnout during long procedures. And we should understand that with the availability of technology, and inevitability in application is obvious. Now, I know that the question of cost is there, the question of availability is there, but this is what the future holds for us. Robot-assisted surgery is here to stay, and we need to look at it critically, just as before with laparoscopy. We need to look at high-quality data on robot-assisted gastrectomy, and most of it has again come from the East. Ojima et al. Published a short-term outcome comparing this feasibility of robot-assisted gastrectomy versus lap-assisted gastrectomy in 2021. It was a phase 3 randomized trial, and they included, again, across the board stages 1, 2, 3. The primary endpoints were post-operative intra-abdominal complications, clavin grade 2 or higher. And in this, they concluded that basically robotic distal gastrectomy did not reduce intra-abdominal infectious complications compared to lap-assisted distal gastrectomy. However, studies from Korea and China also showed that both of them are comparable in the short term. And a large meta-analysis of 40 clinical studies involving around 17,700 patients found that robotic surgery had advantages like reduced bleeding, faster recovery, more lymph node dissection and harvesting, and a lower rates of surgical complications. They did report longer operative time and costs, that is there, and the long-term outcomes are still awaited. A recent study from China, which was published in May of 2024, this year only in Nature, actually changed this perspective a little bit. They evaluated a 3-year disease-free survival as a primary outcome, along with 3-year overall survival. What they found was that when they looked at patients with T1 stage, the 3-year survival, the 3-year survival was almost mirroring the laparoscopic group. But when they extended it to higher stage groups, that is T2 to T4, they actually found that the robotic group was actually doing slightly, if not extremely better than the laparoscopic group. The story was repeated with the nodal burden. In N0 stage, again, the outcomes were mirroring the laparoscopic group. In a bulky nodal disease, again, the robotic group was doing slightly, if not extremely better than the laparoscopic group. When they did an analysis, they showed that overall in the disease-free survival, there was no significant difference at 1-year follow-up. But when they looked at years 1 to 3, the robotic distal gastrectomy showed a survival of 95.3%, and the lap distal gastrectomy showed survival of 83.9%. It did not reach the inferiority criteria for the study, but it is something to look at. Other studies, again, Professor Lee's group published in Surgical Endoscopy showed similar survival rates and recurrence patterns. What we can say is that by looking at this data, at least we can say that this data supports the safety and efficacy of robotic gastric cancer surgery. And further high quality studies are required to validate its presence and if it can actually replace laparoscopy in the near future. Now, when we are talking about minimally invasive surgery, there is a large number of armamentarium that is available to us. The ICG has been used in a number of surgery, biliary surgeries, liver resections, but the ICG near infrared imaging technology has shown promise in early gastric cancer as well as in locally advanced gastric cancer. The idea of laparoscopic sentinel node navigation surgery in early gastric cancer has resulted in a less traumatic surgery to the patient, not requiring an extensive lymph node dissection. In the Senorita trial, they actually published this in 2016 and showed the feasibility of using the laparoscopic sentinel lymph node navigation surgery in only harvesting the nodes that actually showed positive uptake. In advanced gastric cancer, this study from Japan actually showed that this technology was beneficial, not as an early gastric cancer for identifying the nodes, but basically in harvesting a greater number of lymph nodes. In advanced gastric cancer, the extent of lymph node dissection was better by using ICG near infrared imaging technology with a greater number of lymph nodes harvested. Also, this technology has been used for GI anastomosis perfusion analysis. 3D cameras in minimally invasive surgery, that is 3D laparoscopy, has changed the idea about depth perception, but it is unclear in the data whether it actually offers a clear advantage in terms of lymph node dissection, operative time, and blood loss. What it does encourage is it shortens the learning curve in gastric cancer surgical training, especially facilitating precise and complex anatomic steps. Now, concluding with the boom of the AI, and AI and deep learning has found its roots in minimally invasive surgery as well, because AI-based deep learning technology has been integrated in minimally invasive surgery, and it has opened endless possibility in data analytics. This data gathered during procedures, it documents crucial anatomic steps with time and position of the instruments, intraoperative events during which anatomical steppage happened, and it provides the surgeon with a new insight. And the AI and deep learning software actually uses this data to prepare an analysis of the surgeon performance, as well as an entirely database summary of the procedure, which can be used for self-technical standardization, that is self-improvement, as well as for teaching purposes. So the possibilities with AI and deep learning integrated with MIS are almost endless. So the messages that we would take to the OR with this data that we have looked at is that over the last 30 years, MIS for gastric cancer has made significant strides. It has proven itself to be safe and oncologically feasible in the right setting. Minimally invasive surgery for gastric cancer will soon become a mainstream modality with a good look at robotic surgery. And incorporation of imaging technology and data analytics gives a new dimension to minimally invasive surgery. But streamlining of training, vis-a-vis standardization of operative techniques and protocols, and establishment of high-volume centers with robust referrals is key. With this, I thank you all. Thank you, Kapoor sir. I would like to take comments and suggestions.
So before Das takes over, Hamza, two very short questions. One is, for the sake of students, please explain what do we mean by laparoscopic gastrectomy and laparoscopic assisted gastrectomy?
Yes, sir. So basically the term laparoscopic gastrectomy and laparoscopic assisted gastrectomy has been used interchangeably, although they are mutually exclusive as well. A laparoscope assisted gastrectomy would entail a resection and a dissection, which is laparoscopic, and the reconstruction of the GI continuity is done extracorporeally. So that would entail a true laparoscopic assisted gastrectomy. Although in these studies, the terms have been used interchangeably. The true lap assisted gastrectomy would be restoration of GI continuity extracorporeally. And on the other side, if you would do an anastomosis inside and just remove the specimen, it would be a totally laparoscopic gastrectomy.
The second is more a comment, but you can respond to that. To the best of my understanding, I have no personal practical experience of robot, but after having read about it and seen some of my colleagues doing these procedures, I feel the biggest advantage of robot is where the anastomosis is difficult. Resection probably is same whether you do it laparoscopic or robotic. So I feel in a procedure like PD, where the pancreatic anastomosis is the precarious anastomosis, where you sometimes need different angles of movement of the wrist, probably robot will have an advantage. So in gastrectomy, the reconstruction is not a technically demanding part. So from that point of view, and of course, considering the cost, what is your personal opinion after having read and reviewed this topic? In a country like ours, is robot going to play an important role in surgery of the stomach as compared to laparoscopy?
Sir, I would never say never, but the studies that I looked at for robotic surgery, actually it was the lymph node dissection that was the critical part, because the area we're dealing with, and if there is a bulky nodal disease, there is a locally advanced gastric cancer, and you need to get around those nooks and corners, the robot has actually facilitated greater amount of lymph node dissection. As Professor Dash was mentioning initially, that the lymphovascular component of the lymph nodes needs to be taken, and we need to get it right at the pedicle. So in those scenarios, the robot has actually shown a greater number of lymph nodes. Whether harvesting 40 nodes and 45 nodes actually makes a difference in the survival needs to be seen. It's actually a question of stage migration over there. But most of the studies actually mention this only. And some studies have actually shown an earlier return to work. Maybe minimal, but actually an earlier return to work in the robotic group. So it needs to be seen, sir. Obviously, in a country like ours, where we have a lot of cost restraints, till it comes to the public sector, the robot will not truly be assessed.
Das, please carry on.
So that was, thank you, Hamza, and that was a very extensive coverage of the evidences that are comparing the open versus laparoscopy or the minimal invasive. I'm not very sure whether using a hand port would be a pure laparoscopic or a laparoscopic assisted. Some say that using a hand port would be a pure laparoscopic, which I really do not agree, because if you combine all the incisions, it is more than the midline incision that we use for stomach, particularly for stomach. And regarding the robots, if I may be allowed to comment on it personally, then I have looked at the evidences, I've used it, I've seen it, and till now, barring urologic ones. I'm not discussing about the pancreatic one. So far as the stomach part is concerned, it is only helping the surgeons nowadays. How far it would help the patient economically and functionally and all those is yet to be seen. And a lot of senior people, when we discuss, they have also casted similar doubts as I am asking, as I'm suggesting. Now, there's a very interesting observation. If you see the trials regarding the benign conditions in which laparoscopy versus open is the comparison there versus the malignancies. It started with benigns, and it was in the benign conditions, it was mostly the functional aspects of the laparoscopy they were highlighted and shown to be much better. If you see, you can see your trials which you mentioned and the literature. The trials of last 5 years are mostly focusing on the oncological advantage of laparoscopy, non-inferiority of the laparoscopy over the open in the oncological outcome. So they are saying that the oncological outcome is not inferior to open. Now, very few trials and really exhaustively taken into account the functional aspect of the laparoscopy. That the early discharge, the going back to functions, particularly in advanced laparoscopic, advanced stages of cancers where laparoscopic is done. So I am quite hopeful that a lot of these trials are coming up. We'll be getting the results by the end of 24 or early 25, where this thing need to be discussed. That we have no doubt that laparoscopy is not inferior to open so far as the oncological outcome is concerned, but we have to add the functional part and then say that yes, laparoscopy is really superior to open if we combine all these things. Now, tomorrow we will be discussing all these things again, most probably. And we have this overview of management, we have these lymphadenectomies techniques, we have these lab assisted techniques in 3 talks. So I'm not going towards the theoretical part of it or the evidence part of it. Let's little bit focus on the technical part of it, so far the minimal invasive part is concerned. Now, laparoscopy theoretically, if suppose I am going for a gastrectomy, I am feeling the stomach by the instruments. I am losing the tactile part of it. How do I decide that the margin of resection of the stomach in laparoscopy, particularly in small tumors?
Yes, sir. This question has been quite researched, and most of the people who are doing these laparoscopic gastric resections, especially in early tumors, like you said, if there's a small lesion, they take the help of an intraoperative endoscope actually to confirm the resection margin. And in most of these patients, the distal margin is never a problem. It is always a proximal margin that creates some sort of a problem. Another solution would be a preoperative tattooing of the tumor itself. That is also one way, but nothing beats an intraoperative endoscopy. Before you actually go for a resection, you confirm on endoscopy a clear margin, and then depending upon the functional outcomes that you want, you can extend your resection as and when is required.
Rao, please.
So we have a convention to start at 7 and finish at 9. So we have another 7 minutes.
So Dr. Rao wants to say.
Yeah, maybe you can invite brief comments from other panelists. Rao, yeah, Subramanian.
Yes, sir. I think about the lesion localization and the proximal margin. Hamza has actually told us in most situations it's not very difficult, at least in an Indian context, because the tumors are already visible. But the smaller ones, I think the best solution is to do an intraop endoscopy. And if you are an endoscopist, it's always an advantage. Seniors like Kapoor sir have always told us surgeon has to be an endoscopist. Surgeon was the first endoscopist and should continue to be an endoscopist. So best is to see it for yourself, not to believe anybody else as far as anatomy is concerned. If you want to be safe, and if your pathology report should speak about the character of yourself and your surgical resection. And sir, Dr. Dash, how many times would you actually palpate the stomach and understand the margin? Most of the time, it is visual inspection, which actually tells you where you would resect. Palpation would not help except in the diffuse type of gastric cancers. So in open surgery also, a small lesion is not easy at all. A very small lesion is not easy even in open surgery. At least the margin is not easy. You may be able to feel the lesion, but the margin is decided by an endoscopy, even in open surgery. That's what we do. Even if you have to convert for some reason, because we are a very, very high volume minimal access center. We anastomose everything minimal access. So it's not lab assisted, but it is laparoscopic, complete laparoscopic resections. We also do some robotics. Finance are the only constraint. So this problem is extremely rare. It does happen, but it's rare, and we do an endoscopy. We do an on-table endoscopy. Our threshold to do an endoscopy is very, very low, sir.
What about endoscopic tattooing just the day before or on the morning of surgery?
Tattooing is something that we attempted. Surprisingly, I don't know. India ink is something that is not consistently available. You call it India ink, but it is not available in India itself, sir. I don't know.
Yeah. I agree.
Because it is used during elections.
We don't find it here.
Yes,
This
sir.
is what Dr. Ramesh Hamdani told me. It is not available in the market because it is used for marking the finger during the elections.
Oh, really, sir? That is good information,
I
sir.
learned this from Ramesh Hamdani.
We are learning more than science now, actually, from sir.
So just
Then
a small,
Dr. Rao, how do you decide the margin then? That's for the students.
It's endoscopic assessment, sir. Pre-op endoscopic assessment.
How far from the margin, and how are you sure that it's not extending histologically?
Depends on the morphology and the histology, sir. If it's poorly differentiated, if it's a diffuse type, we prefer a total gastrectomy in most of the patients. Otherwise, it's 3 versus 5 centimeters. Depends if it's poorly differentiated, it's 5 centimeters.
So if we are doing a partial gastrectomy, if by definition, if we go by D2 gastrectomy, it would be subtotal or total. But if we suppose we are going by 5 or 3 centimeter, is it advisable to go for margin frozen section?
How much margin can you do frozen section, sir? It's such a long margin. So frozen section is not a very good idea, especially in stomach. And you have a strip of tissue. It may not always indicate what it do. So I think what you mentioned made a passing mention that a subtotal gastrectomy and a total gastrectomy is not a bad idea at all, sir. If you have in doubt, I think subtotal gastrectomy is a wonderful procedure. The rest of the stomach dilates well. Although metabolically it may not be as good as a partial gastrectomy, but in cancer, I think subtotal gastrectomy, total gastrectomy should be the procedures.
Like in rectum, can you reduce the margin if you have used neoadjuvant treatment?
Nobody knows, sir. We don't know the answer because nobody tested this, because the sensitivity of the margin, the preservation of the mucosa of the rectum is much higher, because stoma or no stoma is a very serious consideration. In stomach, you remove 1 more centimeter, patient would never even realize, and it would not hurt you also, because stomach really expands. And a centimeter more is not a problem here. Centimeter more is a serious problem in rectum. So there we could test it. Here, I don't know how ethical it will be to give a smaller margin and try.
For the benefit of students, can one of you quickly explain what is quasi-total or near-total gastrectomy? Because this question we often ask them.
I won't be the right person to Hamza? Sir himself should answer this probably.
Sir, I think it has been part of. Am I audible, sir?
Yes.
You are audible.
This has been part of conventional teaching, near total, quasi total gastrectomy. But what we have found out, especially in cancer, it is subtotal or total gastrectomy now, sir.
That's what.
Sir, I would say quasi actually, if you literally use it, it is less than total. So less than total means it would be a distal gastrectomy. That is not quasi. Quasi means it's just sort of total. That's about what you can say near total. Earlier on, you used to say 95%, then used to say partial, they used to use percentage. So it's a, if you leave the fundus of the stomach, part of fundus of the stomach, you would say that it would be quasi.
So it's 9. I think we will have to close. As I said, we start on time and finish on time. We will continue the discussions tomorrow. I hope all the panelists will join tomorrow also.
Yes, sir.
Yes,
And,
yes, yes.
specifically, first, I would like to thank Das for agreeing to moderate today's session. I would like to thank Dr. Aimon from Myanmar, who accepted our invitation to be on the panel, and all the other speakers, and Sadaf and Anushri, who are actually the panelists tomorrow, but they joined today also, and Subramanyeshwar also. And we will meet again tomorrow at 7 p.m. Tomorrow's session will be moderated by Dr. Vikram Kate, who is the Professor of Surgery at Jaipur.